My name is Janelle Wagner. I am a plastic surgeon at Temple University in Philadelphia. I'm an assistant professor of surgery in the division of plastic surgery. And I specialize in hand surgery, general plastic reconstructive surgery, and peripheral nerve surgery. I get to come in when the patient's already on the operating room table and everything is calm and we're just fixing the problem. And I do a lot of peripheral nerve and a lot of other reconstructive stuff. So I get to do a lot of planning and thinking ahead of time, and that's what I really like to do. When a patient comes in with a traumatic injury, they go directly to the emergency department and they are graded as a trauma, category 1 or category 2. And the trauma team is the first group that really addresses the care of the patient, and they identify the injuries, and once they identify hand or upper extremity injury, that's when they call me. In a trauma situation, your injury is not defined by a particular pathology. It's defined by whatever mechanism of injury it was, and no two injuries are the same. And if it's a life-threatening injury, if the patient is exsanguinating or needs to go to the operating room right away, for example, a distal radius fracture with compartment syndrome, then I take them to the OR right away. Oftentimes I will join the vascular surgery team already in progress doing an arterial repair with a vein graft, and many times there's an associated nerve injury with that. Number one is reestablishing the blood flow to the extremity, otherwise the tissue will die. And once you do that, you can then address your other injuries. The one caveat to that is if you're doing a revasc or replant, you need to establish your bony fixation first, otherwise trying to do a delicate vascular repair and then going back and trying to do a more motion-intensive bony reconstruction is not great. So you want to get your bone fixated first. When a patient comes in who's been shot or stabbed or is dying right in front of you, they go right into that trauma bay and everyone knows exactly what their role is. It's a well-coordinated dance. The resident knows exactly where to go. They're going to put in the chest tube. The ER doc's going to do the intubation. The nurses are going to draw the blood. The intern's going to put the line in, and everyone does their part. So even though it looks chaotic and there's a lot of noise and a lot of running around, it's a very well-defined sequence of events. You have sort of an algorithm as to how you act. And it's A, B, C, D, E. A, airway. B, breathing. C, circulation. D, disability. Is there an open fracture or something like that, deformity. And E, exposure, making sure that the patient is thoroughly examined for all their injuries. It's drilled into you as a trainee. It's a well-practiced routine.